Good afternoon, dignitaries and delegates. I'm Dr. Yogya, resident from MGM Hospital, Navi Mumbai. Today's presentation is about. I hope I'm audible. Today's presentation is about a case of malarial retinopathy, which is presented to our OPD. Introduction. Malarial retinopathy was first described by Lamela et al. In 1993. Retinal hemorrhages, sometimes with subhyaloid extension, papilloedema, retinal edema, retinal pallor are the common findings of malarial retinopathy. These fundus findings are an indicator of poor prognosis in critically ill patients. Malarial retinopathy is commoner in fatal, cerebral and severe falciparum malaria. However, it is rarely reported in uncomplicated cases. The most commonly proposed mechanism of pathogenesis is the sequestration of erythrocytes causing retinal changes. The condition is known to be reversible with no permanent damage to the retina. However, retinal nerve fiber thinning is a proposed late complication in few cases. Moving on to the current case, a 21-year-old male patient of falciparum malaria was referred to the ophthalmology OPD in view of red eyes and sudden onset blurring of vision in both eyes for 2 days. It was progressive and painless and occurred in a febrile context. On examination, the patient had a distant visual acuity of 6/24 in the right eye and 6/18 parts in the left eye, and near acuity of N12 in the right eye and N10 in the left eye. And his color vision was normal in both eyes, and on Amsler's grade examination, he had metamorphopsia in both eyes. Extraocular muscular movements were full, free and painless in both eyes. On anterior segment examination, lids and adnexa were normal in both eyes. Conjunctiva showed subconjunctival hemorrhages on the temporal part of conjunctiva in both eyes, and his intraocular pressure was 18 millimeter mercury in both eyes. This is the anterior segment examination at presentation. Moving on to the posterior segment examination, media was clear in both eyes. Optic disc showed nasally blurred margins, and macula showed subhyaloid hemorrhage in both eyes. Foveal reflex was normal and blood vessels appeared normal, and on peripheral fundus examination revealed retinal hemorrhages and multiple rod spots in both eyes. OCT was done for the patient, which revealed hyporeflectivity at multiple layers with fluid accumulation at macular area suggestive of intraretinal and pre-retinal hemorrhages along with subhyaloid extension at the macula. And few blood investigations were conducted which revealed the peripheral blood smear showed a Plasmodium falciparum parasite, and his complete blood picture was normal. So a provisional diagnosis of malarial retinopathy was made. Intervention: the patient was treated with systemic artesunate and doxycycline along with some vitamin supplements. Patient was followed up regularly with nil ophthalmic intervention. On first follow-up after 5 days, his visual acuity improved to 6/9 in both eyes, and there was a complete resolution of hemorrhages and significant reduction of rod spots and disc edema in both eyes. On follow-up after 2 weeks, his visual acuity drastically improved to 6/6 in both eyes, and also Amsler's grid test was normal with no metamorphopsia, and both eyes anterior and posterior segments appeared normal on slit lamp examination and fundus examination. So these are the pictures of fundus at presentation. The first picture is at presentation, and the second picture is at follow-up after 5 days. And after 2 weeks, patient had completely normal anterior and posterior segment findings. Moving on to the discussion part, the proposed pathogenesis of malarial retinopathy is impaired perfusion, which is likely to be due to the sequestration of infected erythrocytes occurring in retinal microvasculature, which in turn causes hypoxia and ischemia of the retina. The alternate hypothesis for pathogenesis is the release of inflammatory markers from retinal blood vessels. Most common symptoms are retinal hemorrhages at multiple layers, and other findings are disc edema, vessel discoloration, and retinal whitening. Malaria retinopathy is well documented in children by various groups, primarily in Africa and other endemic countries. However, the condition is rarely reported in adults. In a study conducted in India, D.K. Coker stated that 34.1% of cerebral malaria patients were found to have retinopathy-like changes like retinal hemorrhages, blurring of disc margins, retinal edema, and disc pallor, and also hard exudates. Lorenzen et al. Noticed retinal hemorrhages in 14% of patients with cerebral malaria in a study conducted in Thailand. Although the above studies show that retinopathy is well associated with very severe, complicated or cerebral malaria, its association with uncomplicated cases is very rarely reported. Even though malarial retinopathy is directly related to the severity of systemic disease, the post-recovery outcome of visual acuity is remarkably good. Spontaneous resolution is noted in a majority of cases, including current case. A.M. Dondrop et al. Proposed the use of quinine and levimazole has a role in reducing the sequestration of erythrocytes. The role of artesunate and other agents in the condition is still under study. We treated our patient with systemic artesunate and observed satisfactory results. Moving on to the conclusion part, even though malarial retinopathy appears frightening on the first glance, the prognosis is remarkably good without any need of targeted therapy or intravitreal injections. Malarial retinopathy holds diagnostic importance. Henceforth, it is important to rule out malaria in patients presenting with blurring of vision in febrile context. This case report brings to light the rare entity of malarial retinopathy in an adult case of uncomplicated malaria. Malaria has to be ruled out in patients with fever presenting with sudden blurring of vision and retinal hemorrhages. We wish to stress upon the diagnostic importance of condition in an ophthalmologic point of view. Regardless of the frightening nature of condition, it is important to not overtreat the condition. These are my references. Thank you for the opportunity.
Thanks.